cytomegalovirus. So torch infections or congenital infections, you must be knowing them. They include toxoplasmosis, rubella, they include cytomegalovirus, they include herpes. All of these congenital infections can be associated with a small head. The torch infection, which is most commonly associated with a small head, is cytomegalovirus. Then in addition to this, hypoxic ischemic encephalopathy. So we discussed yesterday hypoxic ischemic encephalopathy. So hypoxic ischemic encephalopathy can be another cause of a small head. Then certain syndromes. So I've already told you intake of alcohol during pregnancy resulting in a fetal alcohol syndrome, and intake of phenytoin in pregnancy resulting in a fetal hydantoin syndrome. So these two can result in a small head. Other than these, in addition to these, Down syndrome, Edwards syndrome, and Cry-du-Chat syndrome. Down syndrome is trisomy 21. Edwards syndrome is trisomy 18. So Down syndrome, Edwards syndrome, Cry-du-Chat syndrome. These are three classical syndromes which are present from birth in some children. And the essential feature, or one important feature, not essential, but one important feature of these syndromes is microcephaly, small head. Down syndrome, Edwards syndrome, Cry-du-Chat syndrome, fetal alcohol syndrome, fetal hydantoin syndrome. All of them can also be associated with a small head. So again, one FMG question that I was going through from the FMG book, and this question was, which of the following syndromes is associated with microcephaly? So choice A was Down syndrome, choice B was Edwards syndrome, choice C was Cry-du-Chat syndrome, and choice D was all of these. So answer was all of these: Down syndrome, Edwards syndrome, Cry-du-Chat syndrome, fetal alcohol syndrome, fetal hydantoin syndrome. They are associated with a small head. Which torch infection is associated with a small head? It is cytomegalovirus. Cytomegalovirus is the torch infection which is associated with a small head. In addition, hypoxic ischemic encephalopathy, which I talked about yesterday, is also associated with a small head. So these are the important causes of a small head, also known as microcephaly. And what is the definition of microcephaly? The definition of microcephaly is head circumference of a child which is less than 3 standard deviation from the expected. But this should not be confused with macrocephaly, because macrocephaly is head circumference of a child. Macrocephaly is head circumference of a child which is more than 2 standard deviation from the expected. So what is macrocephaly? Macrocephaly is head circumference of a child which is more than 2 standard deviation from the expected. The important types of macrocephalies is first hydrocephalus. Hydrocephalus is one of the most common causes of a large head in a child. And hydrocephalus typically is associated with large ventricles. What is the typical feature of hydrocephalus? Hydrocephalus is typically associated with large ventricles. If the ventricles are enlarged, then you say this is hydrocephalus. You can never have a hydrocephalus without enlargement of the ventricles. Please remember this. There can be an example of a hydrocephalus when the intracranial pressure is normal. This is known as a normal pressure hydrocephalus. You can have a hydrocephalus when the intracranial pressure is normal, but you can never have a hydrocephalus with a ventricle size normal. Ventricles in the brain have to be increased, dilated, before we say this is a case of hydrocephalus. And yesterday I told you an example of a case where there was a normal pressure hydrocephalus. If you go back to neonatology, when I was doing hypoxic ischemic encephalopathy, and I told you damages which occur in the brain of a term child and a preterm child. In a preterm child, I said there can be only one type of damage that can occur to the brain. And what is that damage? It is known as Peri ventricular Leukomalacia, which leads to which type of hydrocephalus? Normal pressure hydrocephalus. Remember hydrocephalus ex vacuo. So I told you in hydrocephalus ex vacuo, what happens is the white matter which is surrounding the ventricles, it gets necrosed. And because it gets necrosed, now the support on the ventricles disappears, so the ventricles start increasing in size. So ventricle enlargement has to happen before we say this is hydrocephalus. So the most common cause of a large head in a child at birth is hydrocephalus. Then there are two important metabolic disorders which are also associated with hydrocephalus. In fact, three. One metabolic disorder is Tay-Sachs disease. One metabolic disorder is Alexander's disease, and one metabolic disorder is Canavan's disease. Alexander's disease and Canavan's disease are type of leukodystrophies. What is meant by leukodystrophy? They are type of neurodegenerative disorders in which leuco means white matter, in which the white matter is damaged. White matter is myelin. So myelin sheath is damaged. Leukodystrophy. Leuco is white matter, dystrophy is damage to the white matter. The two typical metabolic disorders associated with leukodystrophy are Alexander's disease and Canavan's disease. And both of them are known to present with a large head. So Tay-Sachs disease, Alexander's disease, Canavan's disease, they all present with a large head. So this is an FMG question. All are associated with a large head. Except, so A was Tay-Sachs disease, B was Alexander disease, C was Canavan's disease, and D was Gaucher's disease. Which of them is not associated with a large head? So Tay-Sachs disease, I just now told you, is associated with a large head. Alexander's disease is associated with a large head. Canavan's disease is associated with a large head. But Gaucher's disease is not associated with a large head. So the answer is Gaucher's disease. Gaucher's disease is not associated with a large head. So which are associated with large head? Tay-Sachs disease is associated with a large head. Alexander's disease is associated with a large head. Canavan's disease is associated with a large head, but Gaucher's disease is not associated with a large head. So this metabolic disorder, Gaucher's disease, is not associated with a large head. So please remember which are the metabolic disorders which are associated with large head: Tay-Sachs disease, Alexander's disease, Canavan's disease. So I'll again repeat, which are the types of microcephaly, or which are the causes of microcephaly? Small head. So first I told you is torch infection. Second I told you is hypoxic ischemic encephalopathy. Third I told you syndromes. Which were the syndromes I told you? Two already written on your screen: fetal alcohol syndrome and fetal Hydantoin syndrome. In addition, I also told you Down syndrome, Edwards syndrome and Cry-Du-Chat syndrome are associated with a small head. Now, which are the conditions associated with a large head? In children, the most common condition associated with a large head is a hydrocephalus. Then three metabolic disorders which are associated with a large head. One is Tay-Sachs disease, one is Alexander's disease, one is Canavan's disease. Alexander's disease and Canavan's disease are type of leukodystrophies. When I say leukodystrophy, leuko is white matter, dystrophy is damage to the white matter. So neurodegenerative disorders associated with damage to the white matter are known as leukodystrophies. Two typical type of leukodystrophies are Alexander's disease and Canavan's disease. Both of them are associated with a large head. So the question that you can see at the bottom, all of these are associated with a large head except, so they have given you 4 metabolic disorders and they're asking you which of these metabolic disorders is not associated with a large head. Tay-Sachs disease, Alexander's disease, Canavan's disease and Gaucher's disease. Answer is Gaucher's disease not associated with a large head. Now, just a few words about Just a few words about the ventricles of the brain. So you are typically seeing how the ventricles of the brain function. So first what happens is the CSS is produced, the cerebrospinal fluid is produced, and they are produced by the choroid plexus. Then they enter into the two lateral ventricles. Just see on the brain the two lateral ventricles. From the two lateral ventricles, the CSF then enters down into the third ventricle, flows down into the fourth ventricle. Then from the fourth ventricle, the CSF gets absorbed through the subarachnoid villi. So these are like these projections which are present. So CSF gets absorbed through the subarachnoid villi and then flows in the basal cisterns in the brain. Now please remember, any obstruction that occurs, till the level of the ventricles, that means till here any obstruction that occurs will result in a type of hydrocephalus which is known as obstructive hydrocephalus. But any obstruction occurs outside the level of the ventricles will result in non-obstructive hydrocephalus. So try to understand, any obstruction that occurs to the CSF flow while the CSF is still inside the ventricles will result in a type of hydrocephalus which is known as an obstructive hydrocephalus. So the obstruction can occur either at the level of foramen of Monro, which is the exit point between the lateral ventricles and the third ventricle, or it can occur at the level of aqueduct of Sylvius. You know what is aqueduct of Sylvius? Aqueduct of Sylvius. You all know what is aqueduct of Sylvius. Aqueduct of Sylvius is the part between the third ventricle and the fourth ventricle. So aqueduct of Sylvius is the part between the third ventricle and the fourth ventricle. So when the CSF comes out from the third ventricle, it has to pass through the aqueduct before it enters into the fourth ventricle. Please remember, aqueduct of Sylvius is the narrowest part of the ventricles. The narrowest part of the ventricles is the aqueduct of Sylvius. So because it is the narrowest part of the ventricles, it is the part which is most likely to get obstructed. So I told you now, any obstruction to the CSF flow which occurs inside the ventricles will result in a type of hydrocephalus which is known as obstructive hydrocephalus. And because the aqueduct of Sylvius is the narrowest part of the ventricles, so what is the most common place where obstructive hydrocephalus will occur? It is the aqueduct of Sylvius. Please remember this, the narrowest part of the ventricles is aqueduct of Sylvius. So the part of the ventricles which is most likely obstructed and will therefore result in an obstructive hydrocephalus is known as aqueduct of Sylvius. So aqueduct of Sylvius, being the narrowest part, is the most likely place where obstruction to the CSF flow occurs. Once the CSF has come out of the lateral ventricles, fourth ventricle. So now the CSF, after it has come out of the fourth ventricle, either there is problem, just see the red line on the screen, either there is problem in absorption through the subarachnoid villi, or there is flow in the cisterns, there is obstruction to the basal cisterns, but no obstruction is happening inside the ventricles. No obstruction is occurring inside the ventricles. This type of hydrocephalus is known as a non-obstructive hydrocephalus. So while an obstructive hydrocephalus is always an obstruction inside the ventricles, a non-obstructive hydrocephalus is always an obstruction outside the ventricles. I hope now it is very clear. Hydrocephalus can be of two types. It is either obstructive or it is non-obstructive. Obstructive hydrocephalus always occurs because of an obstruction to the CSF flow inside the ventricles. So inside the ventricles, whenever there is an obstruction, Above the obstruction, the ventricles will start dilating. That is why we say this is obstructive hydrocephalus. The ventricles have started dilating. But if the obstruction is outside the level of ventricles, so the CSF normally pass through the lateral ventricle, pass through the third ventricle, pass through the fourth ventricle, but the moment it starts getting absorbed through the subarachnoid villi or flows in the basal cistern, some obstruction starts happening now. This is known as a non-obstructive hydrocephalus. So obstruction is occurring outside the level of ventricle. So behind all the ventricles will get dilated because CSF will start accumulating there. So that type of hydrocephalus is known as a non-obstructive hydrocephalus. So obstructive hydrocephalus always because of an obstruction inside the ventricles. Non-obstructive hydrocephalus always because of an obstruction outside the ventricles. The part of the ventricles which is the narrowest part of the ventricles is the aqueduct of Sylvius. Therefore, this is the place which is most likely to get obstructed in an obstructive hydrocephalus. So please see this. What is hydrocephalus? Hydrocephalus is a large head due to large ventricles. Obstructive hydrocephalus always results from an obstruction inside the ventricles, and because the aqueduct of Sylvius is the narrowest part of the ventricles, this is the part which is most likely to get obstructed. So this is again an FMG question. Which is the most common cause of an obstructive hydrocephalus in children? The most common cause of an obstructive hydrocephalus in children is a congenital aqueductal stenosis. It is congenital narrowing of the aqueduct from birth. This is the most common cause of an obstructive hydrocephalus. Most common cause of an obstructive hydrocephalus in children is a congenital aqueductal stenosis. Congenital, from birth it is present. But are there some acquired causes? That means when the child was born, he was normal, but later on went on to develop a obstructive hydrocephalus. Obstructive hydrocephalus means obstruction inside the ventricles. So can there be certain infections which can cause an obstructive hydrocephalus? Yes, there are two important acquired causes of obstructive hydrocephalus. Which are those infections which can lead to obstructive hydrocephalus? One is mumps, one is toxoplasmosis. So mumps and toxoplasmosis are two important causes which are causes of acquired hydrocephalus. So remember I told you which is the most common torch infection associated with microcephaly. I told you it was cytomegalovirus. So now if I ask you which is the most common torch infection associated with macrocephaly or hydrocephalus. So answer will now become toxoplasmosis. So which is the most common torch infection which is associated with microcephaly? It is cytomegalovirus. But which is the most common torch infection associated with macrocephaly or a large head? It is toxoplasmosis. So two important acquired causes of aqueductal stenosis, infections associated with aqueductal stenosis. One is mumps, one is toxoplasmosis. Toxoplasmosis is a torch infection which is commonly associated with a large head. Please remember, toxoplasmosis can present with a small head also, but more commonly presents with a large head, macrocephaly or a hydrocephalus. And which type of hydrocephalus does it cause? It causes an obstructive hydrocephalus. Right? So the most common cause of obstructive hydrocephalus is congenital aqueductal stenosis, and two infections which are associated with obstructive hydrocephalus are mumps and toxoplasmosis. Which is the most common which is the most common cause of non-obstructive hydrocephalus? The most common cause of non-obstructive hydrocephalus. Non-obstructive, I told you, can occur Non-obstructive, I told you, can occur because of non-obstructive can occur because of obstruction occurring outside the ventricles. So either it is obstruction in the absorption through the subarachnoid villi, or it is obstruction in the basal cisterns. So the most common cause of a non-obstructive hydrocephalus is subarachnoid hemorrhage. So which was the most common cause of obstructive hydrocephalus? It's an FMG question. Answer is congenital aqueductal stenosis. But the most common cause of a non-obstructive hydrocephalus is a subarachnoid hemorrhage. So hydrocephalus, let me quickly revise. Hydrocephalus can be obstructive, it can be non-obstructive. Obstructive hydrocephalus, always due to obstruction inside the ventricles. Non-obstructive hydrocephalus usually is obstruction outside the ventricles. The narrowest part of the ventricle is the aqueduct of Sylvius. So the most common cause of obstructive hydrocephalus is a congenital aqueductal stenosis. Are there certain infections which can also cause obstructive hydrocephalus? Yes. One is mumps, one is toxoplasmosis. So which is the most common torch infection associated with a microcephaly, small head? It is cytomegalovirus. But which is the most common torch infection associated with a macrocephaly? It is toxoplasmosis. And regarding non-obstructive hydrocephalus, it is always due to an obstruction outside the ventricles. The most common cause of a non-obstructive hydrocephalus is a subarachnoid hemorrhage. So you can see here, these are the two lateral ventricles. These are the lateral ventricles. LV is the lateral ventricles, and this is the foramen of Monro. Then this is the third ventricle. And then this is the aqueduct. You can see this is the aqueduct. So this is the place where most commonly obstructions occur. So this is the aqueduct where most commonly obstructions occur. So blockage inside the ventricles can lead to an obstructive hydrocephalus. Blockage outside the ventricles leads to a non-obstructive hydrocephalus. Now there are just three important things that I would additionally like to tell you. Two important disorders that I would like to discuss. One is known as an Arnold Chiari malformation. The other is known as a Dandy-Walker syndrome. Please try to understand the picture that is there in front of you so that you can understand this. You can see the two lateral ventricles. So these are the two lateral ventricles. So this is the lateral ventricles. This is the lateral ventricle, LV. Then this is the third ventricle. This is the aqueduct. You can see this is the aqueduct. This is the fourth ventricle. You can see the fourth ventricle. The circled portion is the fourth ventricle. I hope you can appreciate the fourth ventricle is the circled portion. The circled portion is the fourth ventricle. Now, this is the cerebellum. So this is the cerebellum. Now, in some children, now please try to understand what I am saying. In some children, what happens is the cerebellum, please pay attention to what I am saying. Don't start writing. Please first understand what I am saying. In some children, the cerebellum, which lies in the posterior fossa, this is the posterior fossa of the brain. The black portion is the posterior fossa of the brain. This black portion. This is the part of the posterior fossa of the brain where the cerebellum lies. Now, in some children, this cerebellum the posterior fossa is so small that the whole cerebellum cannot lie in the posterior fossa. So the posterior fossa is very small, congenitally from birth. So the cerebellum, because it cannot lie completely, the lower part of the cerebellum or probably the whole of the cerebellum will herniate down into the foramen magnum. So you are seeing here the cerebellar tonsils. You are seeing this circled portion. The cerebellar tonsil is moving down or herniating down into the fourth ventricle. And when it herniates down into the fourth ventricle is also passing here. So what happens is the cerebellar tonsils, it starts compressing the fourth ventricle. I'll repeat again. In some children, the posterior fossa is very small. So it is so small that it cannot completely keep the cerebellum in position. So the lower part of the cerebellum, which is also known as the cerebellar tonsils, you can see written here, cerebellar tonsils, it herniates down into the spinal cord. When it herniates down, it starts compressing the fourth ventricle, which is also passing through the spinal canal. So it's also passing. So it starts compressing the spinal canal. And when it starts compressing the spinal canal, it can result in an obstruction inside the ventricles because it is obstructing the fourth ventricle. Remember, obstruction inside the ventricles is known as obstructive hydrocephalus. So it can result in an obstructive hydrocephalus. What is this condition called? This condition is known as Arnold Chiari malformation. There are many types of Arnold Chiari malformations, type 1, type 2. Please remember, it is type 2 Arnold Chiari malformation which is more commonly seen in childhood. So symptoms of hydrocephalus and a myelomeningocele. Hydrocephalus, I told you why will happen, because this herniating cerebellum will compress the fourth ventricle. So it can lead to obstructive hydrocephalus. Along with obstructive hydrocephalus, Arnold Chiari malformation type 2 is commonly associated with myelomeningocele. I told you the neural tube defect which is most serious is myelomeningocele. So I hope you have understood what is Arnold Chiari malformation. It results because of a very small posterior fossa. So the skull base of these children is very flat from outside. So normal curve of the skull base is not present. It is flat from outside. So the posterior fossa is very small. So the lower part of the cerebellum it herniates down. And when it herniates down, it starts compressing the ventricles. Which ventricle? The fourth ventricle, which is also passing through the spinal canal. So the fourth ventricle is compressed by the lower part of the cerebellum. You can see the orange portion in the picture. So that cerebellar tonsil is compressing the fourth ventricle. And when the fourth ventricle will get compressed, above all ventricles will start dilating. This is known as Arnold Chiari malformation. There are many types of Arnold Chiari malformation, mainly type 1 and type 2, but there are other types also. The one which is commonly seen with symptoms in infancy is type 2. Type 2 Arnold Chiari malformation is usually associated with a combination of hydrocephalus and a myelomeningocele. So if someone asks you which disorder is commonly associated with both hydrocephalus and a myelomeningocele, you will say it is Arnold Chiari malformation type 2. So let me write it here. Arnold Chiari malformation. It results from a small posterior fossa as shown by a skull base which is flat in some children. So the skull base is flat in some children. So these children have a very small posterior fossa. As a result, lower part of the cerebellum or sometimes the whole of the cerebellum herniates down into the foramen magnum. So what is foramen magnum? Foramen magnum is the spinal canal. So it herniates down into the foramen magnum. This compresses the fourth ventricle and can result in a hydrocephalus. This compresses the fourth ventricle and can result in a hydrocephalus. So the one which is seen in infants is which type of Arnold Chiari? There are many types. I told you type 1 and type 2 are the most common, but there can be other types also, type 3 also, type 4 also. So the one which is seen in infants is type 2 Arnold Chiari, and type 2 Arnold Chiari is always associated with hydrocephalus along with a myelomeningocele. So a combination of hydrocephalus and a myelomeningocele is seen in Arnold Chiari malformation type 2. If they ask you in the exam, a combination of hydrocephalus and myelomeningocele is seen in which disorder? It is seen in Arnold Chiari malformation type 2. So just repeating once again, a small posterior fossa, flat skull base, small posterior fossa. So the lower part of the cerebellum, it herniates down into the foramen magnum. Or sometimes the posterior fossa can be so small that the whole of the cerebellum will herniate down into the foramen magnum. Foramen magnum is the spinal canal. Now through that foramen magnum, it's a tube through which the spinal cord passes. It's a tube. So through that foramen magnum, the fourth ventricle is also passing. And now the cerebellum also passes. So the cerebellum will compress the fourth ventricle. And when the fourth ventricle will get compressed, an obstruction is occurring inside the ventricles. So behind hydrocephalus, dilatation of the ventricles can occur. Which is the type which is seen in infants? The one which is seen very early in life is type 2 Arnold Chiari malformation, where there is a combination of hydrocephalus with a neural tube defect which is known as myelomeningocele. So someone asked you, hydrocephalus with a myelomeningocele is seen in which type of disorder? It is seen in Arnold Chiari malformation type 2. I hope you have understood this. So I hope you have all understood this. Now let me come to another disorder which is slightly different from this disorder, but because this also involves the cerebellum, so I will talk about this disorder here only. What is the name of this disorder? The name of this disorder is a Dandy-Walker syndrome. So I don't know if you can... So what is a Dandy-Walker syndrome? See, this is exactly opposite to what was happening in Arnold Chiari malformation. Just pay attention now. Just pay attention now. So what was happening in a Dandy-Walker syndrome? The posterior fossa, what was happening in Arnold Chiari malformation? The posterior fossa was very small. Now let us talk about Dandy-Walker syndrome. Please just pay attention to the portion where I have marked a arrow. Just pay attention there. The roof of the fourth ventricle, the blue colored fourth ventricle, you can see the blue colored fourth ventricle. The roof of the fourth ventricle is in contact with the base of the cerebellum. You can see there, the point where I have marked a black arrow. The base of the cerebellum is in contact with the roof of the fourth ventricle. So sometimes what happens is when the CSF comes down from the third ventricle into the fourth ventricle, the roof of the fourth ventricle, because it is not properly developed, a large cyst starts to develop in the roof of the fourth ventricle. You can see the black colored portion, this cyst. And this cyst always is seen to fill up the posterior fossa. So the cyst starts compressing the cerebellum. So the cyst starts to form, and the cyst is filled up with a cerebrospinal fluid, and it starts to compress the cerebellum. It is always seen in the posterior fossa because the posterior fossa is the part where the cerebellum lies. So for us to say this is Dandy-Walker syndrome, there should be three criteria. What are the criteria? First, there should be a cyst in the posterior fossa. You can see a black colored cyst in the posterior fossa. Second, the cyst should be arising from the fourth ventricle. You see it is arising from the fourth ventricle. And third, the cyst should be compressing the cerebellum. So if all the three criteria are met, you can see the cyst is a posterior fossa cyst. The cyst should be arising from the fourth ventricle, and the cyst should be compressing the cerebellum. If all these three criteria are met, then we say this condition is known as a Dandy-Walker syndrome. So because of the cyst in the posterior fossa, the posterior fossa appears to be very big in size. So this is exactly opposite to Arnold-Chiari malformation. Arnold-Chiari malformation, I told you the posterior fossa is small. In Dandy-Walker syndrome, because of the cyst, the posterior fossa appears to be very big. You understand? So for us to say this is a Dandy-Walker syndrome, there should be three things. There should be a cyst in the posterior fossa. The cyst should be arising from the fourth ventricle, and the cyst should be compressing the cerebellum. Any one of these criteria is not met, this is not a Dandy-Walker syndrome. For us to say this is Dandy-Walker syndrome, all these three criteria should be met. There should be a cyst in the posterior fossa, the cyst should be compressing the fourth ventricle, and the cyst should be arising from the fourth ventricle, and the cyst should be compressing the cerebellum. If all these three criteria are met, we say this is a case of a Dandy-Walker syndrome. So Arnold-Chiari malformation, a small posterior fossa. Dandy-Walker syndrome, a large posterior fossa. Arnold-Chiari malformation, cerebellum herniating down and compressing the fourth ventricle. Dandy-Walker syndrome, cyst in the posterior fossa, which is compressing the cerebellum. So I always teach my students like this: Arnold-Chiari malformation and Dandy-Walker syndrome are two opposite things. In Arnold-Chiari malformation, what is happening? The cerebellum is compressing the fourth ventricle. But in a Dandy-Walker syndrome, a cyst from the fourth ventricle is compressing the cerebellum. I hope there is no confusion. In a Arnold-Chiari malformation, I told you the cerebellum which is herniating down is compressing the fourth ventricle. But in the case of a Dandy-Walker syndrome, a cyst which is arising from the fourth ventricle is compressing the cerebellum. If you can see this image, just see this image. This is normal. You can see this portion. This is the C portion, is the cerebellum. And you can see the fourth ventricle. 4V is the fourth ventricle. And this is the lateral ventricle. Just see, LV is the lateral ventricle. Now see what happens in a Dandy-Walker syndrome. You can see now Dandy-Walker syndrome. So in a Dandy-Walker syndrome, now what has happened? Now the cerebellum has become this. Now see, just see the cerebellum here. This is the cerebellum. This was the cerebellum in normal condition. And see what has happened to the cerebellum. The cerebellum has become this small. Why? Because now there is a large cyst which is present in the posterior fossa. And this arrow shows, the small arrow, the small white arrow shows the cyst is arising from the fourth ventricle. So cyst is arising from the fourth ventricle, cyst is present in the posterior fossa, and cyst is compressing the cerebellum. All the three criteria are met. This is a Dandy-Walker syndrome. And see what has happened to the lateral ventricle. See the size of the lateral ventricle. This was the lateral ventricle in normal condition. And see, this is the lateral ventricle now. The lateral ventricles are massively dilated. So because of this dilatation of ventricle, this is also a type of hydrocephalus. So Arnold-Chiari malformation, it is the cerebellum which is compressing the fourth ventricle. In a Dandy-Walker syndrome, it is a cyst from the fourth ventricle which is compressing the cerebellum. The next group of disorders that I now come to is a disorder which is known as Craniosynostosis. Please pay attention now. Till now I was telling you abnormalities in the head size, that means a small head or a large head. Now I'm talking about abnormalities in the head shape. Now when I say abnormalities in the head shape, there is abnormal head shape because of premature fusion of the skull sutures. What is this disorder called? This disorder is known as Craniosynostosis. It is an autosomal dominant disorder. So what is Craniosynostosis? It is abnormal head shape which occurs because of premature fusion of the skull sutures. So the skull sutures, they normally fuse at a particular time. Which is the first suture to fuse? So you can see these sutures, the suture, metopic suture. Metopic suture is between the two frontal bones. Then you can see the coronal sutures. These are the coronal sutures. These are the coronal sutures, both coronal sutures, bilateral coronal sutures. Then this is the metopic suture. Then you can see this sagittal suture, this long suture is the sagittal suture. And then you have the two lambdoid sutures. So these are the lambdoid sutures. So these are the sutures which you should primarily remember for your exams. In front, between the frontal bones, you have the metopic suture. Then you have the coronal sutures, which is between the frontal and the parietal bones. Then you have the long sagittal suture, which is running in the center. And then you have the two lambdoid sutures at the back. Metopic suture in front, please pay attention to them. Metopic sutures in front, then the coronal sutures bilaterally. So this is unilateral, one coronal suture, this is the other coronal suture. Then you have the big sagittal suture which is running in the center between the two parietal bones. And then you have at the back, you have the lambdoid sutures. So one lambdoid suture on one side, one lambdoid suture on the other side, both lambdoid sutures. Which is the first suture to fuse? The first suture to fuse is the metopic suture. And when does it close? It closes at 2 months. Don't confuse it with the first fontanelle to close. The first fontanelle to close was the posterior fontanelle. I told you posterior fontanelle, then sphenoid fontanelle, then mastoid fontanelle, last to close is the anterior fontanelle. But among the sutures, the first suture to close is the metopic suture. When does it close? It closes at around 2 months of age. So premature fusion of these sutures. Metopic sutures, they close at about 2 months, and then coronal, sagittal and lambdoid sutures, they close somewhere around 26 to 28 months. So metopic is the first to close at about 2 months, and then coronal, sagittal, lambdoid, they close somewhere around 26 to 28 months. If these sutures close earlier than expected, earlier than the times of closure, then they can result in abnormal head shapes, and these abnormal head shapes is what is known as craniosynostosis. So what is craniosynostosis? It is premature fusion of the skull sutures which leads to an abnormal head shape. So you can see a normal head shape, and here you can see an abnormal head shape. Craniosynostosis can run in families as an autosomal dominant disorder. So it can run in families as an autosomal dominant disorder. So please don't confuse it with abnormalities in the head size. In abnormalities in the head size, the shape of the head remains the same, but the size of the head may be either small or it may be big. So it may be microcephaly, it may be macrocephaly. But when the shape of the head is abnormal, and why is the shape of the head abnormal? Because the head, because the sutures, they fuse prematurely, earlier than the normal. Then it results in abnormal head shape. Now there is no abnormality in head size, there is abnormality in head shape. What is this condition called? It is known as craniosynostosis. We'll just see how the premature fusion of these different sutures, metopic, coronal, sagittal, lambdoid, how it can lead to different types of head shape. Which is the first suture to close? It is the metopic suture. So let us go one by one. So this is a normal head shape that you are seeing. This is a normal head shape that you are seeing. Now see, the first type of craniosynostosis which occurs because of premature fusion of the sagittal sutures. This was the sagittal suture. So the sagittal suture has fused prematurely. As a result, the head is now elongated like this. This elongated board-shaped head is known as scaphocephaly or dolichocephaly. So what is scaphocephaly? When the sagittal sutures fuse prematurely, other sutures on time, then this type of craniosynostosis is known as scaphocephaly. It is also sometimes referred to as dolichocephaly. which is the most common type of craniosynostosis in children? The most common type of craniosynostosis in children is this, kyphocephaly or dolichocephaly, which is premature fusion of the sagittal sutures. You can see the shape of the head. The shape of the head suddenly becomes elongated like a boat. Yesterday I told you, when I was telling you scaphoid abdomen, boat-shaped abdomen. So this is a boat-shaped skull. So what is kyphocephaly? It is boat-shaped skull, which is because of premature fusion of which sutures? It is because of premature fusion of the